Is it moving?
Yes, it is moving. Yeah.
Okay. I'll start whenever you say.
Yeah, no, we'll go ahead. We can go ahead.
Well, thank you once again for having me to discuss something which I'm very, very passionate about. This is the medical record keeping, or documentation as we like to call it. This is something that doctors refuse to learn over the years. This is something we have been trying our level best. Even our professors used to make their best of efforts. I'm sure the teachers in medical colleges also make an effort in this direction. But this is something that we just refuse to learn, and whatever little we used to do as residents, the moment we become consultants and we come out, we tend to forget even that. So if from this talk today, you have to take one image as a message, I will request you to take this image as a message. And if you can understand this image, the job is done. We don't need to discuss anything further regarding medical records. So basically, however much hard work you may have done, until the paperwork is done, the job is not complete. This is something you have to understand very well. And when we discuss the medical record keeping, these are the headings we will be discussing it under: whether medical records are evidence, why documentation is needed, what to document, when to document, how to document, where to document, what not to do with documents, where to store, how long to store, and what documents to give to patients. The first question which arises is, are medical records evidence at all? Because there is something called hearsay rule. Hearsay rule holds that one person cannot testify about the truth of what another person has said. Now, the problem with medical records is some resident has taken history from the father, mother, relative, patient, and written that history. He may not be available even for cross-examination when the case comes to court. Even the resident may not be available. So this evidence actually becomes hearsay, and hearsay rule does not permit this to be included as evidence. So if this kind of a statement which is made out of court is accepted as evidence, the person making that statement cannot be cross-examined about the truthfulness about it. This is the reason there is a problem in considering medical records as evidence. But if this rule was applied to medical record, everyone who made an entry in the record would have to be called into the courtroom, and this cannot be done. So because of these practical difficulties, the courts have created a business record exception to the hearsay rule. This business record exception says that documents may be admitted into evidence without the requirement of the persons who made the entries to be available for cross-examination if the records are kept in normal course of business. If as normal course of business you keep those records, then those records will be accepted as evidence in courts. And Indian Evidence Act 1872 mentions that medical records are acceptable.
Still, yeah. Unless it is mentioned in previous Roznama that
somebody needs to mute.
Otherwise, then in after.
So sorry, can I just ask whoever is speaking to please mute yourself?
Because some of the judges, sorry.
Can you please mute yourselves?
Is poor medical record keeping an advantage? Medical records can be legally disastrous if it demonstrates incompetence of underlying medical care. So poor documentation is actually an advantage to an incompetent defendant whose best defense is obfuscation. The poor record may prevent medical care providers from establishing the good care they gave the patient, but a good record is not a substitute for good care. And although courts usually give a doctor benefit of doubt in ambiguous matters, this does not extend to ambiguities created by incompetent record keeping. And the classical examples, the least credible, are where there is inconsistency in the records. A physician progress note says one thing, the nurse's record says another thing. These are the kind of inconsistencies which will be picked up immediately by the judiciary, and these will be taken as negligence per se. The next question which comes is, why do we need to keep medical records? Three basic reasons. One, courts accept them as evidence, and they accept them in the sense that it helps the doctor to prove the treatment was carried out properly, and poor records mean poor defense, no records means no defense. This is something well accepted by courts. So if you have done everything, but you have not recorded it properly, the courts will assume that you have not done the job properly. So one, for this reason, you need to document. Second reason is 2002 Amendment of Consumer Protection Act 1986 had said that in case of death of the defendant or the complainant, the claim will not abate. And 2019 CPA also follows Civil Procedure Code, where a claim will not abate with the death of one of the parties. What does this mean? This means tomorrow, while contesting the allegation against me, if I die, the case will not die with me. The case will continue against my estate, against my legal heirs. And if I have not created good medical records, they will find it very, very difficult. They will find it very, very difficult to defend themselves. Then your indemnity insurers, whom you think they are your friends, will refuse to pay any compensation awarded if your medical record keeping is not up to mark and you do not provide the indemnity insurers medical records when they ask for it. So this is one case which I have quoted here on all these things. And this is a very old Chinese proverb that a faintest ink is more powerful than the strongest memory. Please remember the importance. Now, what happened in this case? Apollo Hospital, Hyderabad, has 2 branches, and a patient with crush injury left arm was being treated in one of the Apollo hospitals and needed to be shifted to the other hospital for better management. Patient died. The hospital records while being shifted were lost. All the doctors who were treating the patient in both hospitals were the same. So from their memory, they gave affidavits in court. This is exactly what had happened. This is the discharge summary, or this is the death summary which we have prepared. The court said this affidavits of the doctors from memory is not a substitute for medical records. And this was dismissed. The case, the compensation was awarded in this particular case. Then is the issue of what constitutes medical records. Basically understand one thing. If you are making a video of a surgery, even that is part of the medical record. If the patient party knows you have made a video, he can ask for the video and you will have to provide. You can charge for the same, but you will have to provide as part of the medical records. So all your consents, all your progress notes, all the nurses' charts, all these are part of medical records. Even if a patient goes to the extent of asking the attendance of the nurse who is looking after the patient, whether the nurse was on duty that day or not, or how many nurses were on duty that day, the hospital under RTI in a government institution and otherwise also may also need to provide these kind of data. Why? Because even under Clinical Establishment Act, which is covering everything, the types of records include many, many things. And if you look at this, these are the records to be maintained by a clinical establishment. And all these tomorrow may be asked to be produced before an appropriate authority. Next is the question, what do you document? What you document, classical example is Kunal Saha case. Here, the patient remained in AMRI Hospital, Calcutta for 4 days. The patient remained in Breach Candy Hospital for 12-13 days. The patient died in Breach Candy Hospital. A total of 11.6 crores, including interest, was awarded in the case. Entire amount was against AMRI Hospital. Nothing was awarded against Breach Candy Hospital. Why was this? The reason was the medical records of Breach Candy Hospital were so elaborate that they were damaging to the case of Dr. Kunal Saha, and so damaging, in fact, that National Consumer Dispute Redressal Commission, when deciding the case, awarded 1.73 crores as compensation and said because of contributory negligence of Dr. Kunal Saha himself, he himself has to pay 10%. So when he went to court, the Supreme Court, for enhancement of the compensation, he was advised to drop the Breach Candy Hospital from the array of opposite parties. Why was this done? Look at the records created by the Breach Candy Hospital. The Dr. Udwadia, a very senior person, what is he writing in the progress notes? I have never used the drug. I am totally unfamiliar with it and feel we should use drugs we are familiar with. Dr. Kunal Saha and his brother, both were insisting on use of certain kind of antibiotics, which they had brought from US. Dr. Udwadia says, I have had great problems with husband and brother-in-law. It was with great difficulty I have controlled myself. Things like this happen daily in all hospitals with all doctors. The nurses mentioned that doctors have advised 4 liters of DNS to be given till the morning, which was not transfused on the collective request of patient and her husband. So these are the kind of things which we normally do not put down in our progress notes. But this is what saved Breach Candy Hospital. So please keep in mind what kind of things you document, and do not think that a disagreement with the patient, you have counseled a patient for surgery, the patient doesn't want to get the surgery done, there's an altercation. Kindly document everything besides the other medical records that you create. Then this case, Indu Sharma versus Apollo Hospital, Delhi. Patient complained that no CTG graphs were given at discharge. Hospital claimed these were given. But the hospital could not produce a signed refusal of consent for cesarean by the patient or the husband. The hospital had said, we had advised cesarean number of times. The patient, who was a BMS doctor, refused to sign the consent for cesarean, which is why cesarean got delayed. Now the problem was, if the patient was not giving consent, it was their duty to get a refusal of consent signed by the patient, which again they did not. Another lapse in operation notes. Patient taken to OT, administered spinal anesthesia. Patient had an arrest, resuscitation done, but patient went into coma. The court says operation notes do not mention as to the time taken to get the heartbeat back. What was the time when arrest occurred? Who noticed the arrest? Who started resuscitation? And how much time it was taken to bring the heart back? These are also the kind of things the courts are demanding that these be told to us, these be recorded in the medical records. Similarly, in this particular case, no record that either the physician or the anesthetist certified the patient fit for surgery, posted next day for fracture upper arm, leading to immediate post-operative death. Now, a pre-operative assessment is, PSC is routine. Every hospital nowadays does it, but sometimes we don't document it. The anesthetist will come and do rounds and mention it. The hospitals which have a checklist and which have a complete the NABH protocol which they are following, or the JSE protocol which if they are following, the thing is they will have this, but the problem occurs mostly in small and medium healthcare establishments where a physician has seen, given fitness, and the posted for surgery, or the anesthetist has already seen the patient, or the anesthetist comes from outside before giving anesthesia, he does the pre-anesthetic checkup. But this has to be documented. If you have not documented this, you are considered not to have done this. So inconclusive post-mortem report will not absolve negligence of doctors and compensation of 13 lakhs was awarded in this particular case. After surgery instructions, sometimes we forget putting them down. This is very, very important, and unless and until you do this, it's a problem. Even after surgery or even without surgery, in an OPD, you have advised the patient. There was a patient who was advised mitomycin C drops in the eye to be put, but it was not mentioned for how many days. So the patient went on going to the chemist, buying the medicine and kept putting in the eye for 6 months. The problem with the medicine, the eye got damaged, and then they filed a case. I was never told this is to be put only for 7 days. The court held that this was correct and the doctors should have, but then they also held that there was contributory negligence of the patient, that rather than keeping buying from the market, they should have consulted the doctor after the one while was over, or they should have consulted, not carried on taking indefinitely. Another case regarding consent, in this particular thing, the National Consumer Dispute Redressal Commission, this patient was with abdominal pain many times over 2 days consecutively, and possibility of twisted ovarian mass could not be ruled out. But multiple times the patient had been seen earlier within the last 2 days. Surgery was done in an urgent basis, but consent was not taken because this was an urgent surgery. Now, the medical records in the file also did not show operative details, the procedure, details of assessment of viability of strangulated intestines. Somebody is not.
Robert, can I just, please. Yeah, I think he has muted himself. Yeah.
So you need to document things which we observe, we do according to what we observe, but we don't document these things. And sometimes the consultant is operating, he has seen the viability of the intestines, he has not resected because he considered the intestines to be viable, but he has not communicated this to the resident. And when the resident is writing the operative notes, he does not mention anything about the viability. This is where problems arise. Then appendectomy conducted without mandatory tests. So not maintaining hospital records of day-to-day treatment itself amounts to deficiency of services, even though you may have done the surgery perfectly. And this particular case, Sanjay Mutha versus Jayashri Desai, I can keep talking on this case for a different reason, because there was a comment by the High Court judge in this particular case. This was I'm forgetting which state, but this case had gone in criminal court to High Court also. And there the judgment, there was a line there which caught my attention, which said, had Shrimati Rupa Mutha died during surgery, it may not have given that much distress to the family of the deceased, of the patient, as the situation is now when the patient is in vegetative state. So this was a very provocative. Okay. So this was a very provocative statement. Effectively, the court was saying, after arrest, if the patient had died, it may have been better, rather than the patient now being in vegetative state. This is now totally against what medical norms, medical ethics, medical teaching is. When a patient arrests, we don't stop to think whether we'll be able to revive the patient to the extent that they will not have any neurological deficit. There's no way to guarantee that. But this was the judgment by the High Court. And in the National Consumer Dispute Redressal Commission, the issue raised in this was that you should have brought the pulse oximetry record. And since that was not available, so it could not be proved that the doctors had done everything that was necessary and the anesthetists were maintaining the patient's SpO2. 38 lakhs compensation was awarded in this case. Next is the issue of how to document. Documents should be clear, comprehensive, complementary, and contemporaneous. What do these terms mean? This is very, very obvious how our handwriting changes. So these records will never be clean. Number two, when you create a medical record, if you do not sign under the record, that unsigned medical record has no legal validity. Number three, Rishabh Sharma case, everybody should read. Rishabh Sharma case, everybody should read, because in this particular case, what had happened was ROP had occurred in a premature child, and the doctors had written on 24th day or so that no ROP seen. The court said this is not sufficient. You should have written that you have performed a retinal examination with binocular indirect ophthalmoscope on dilatation of pupil with scleral depression to ascertain avascular zone at periphery of retina. Writing no ROP seen is not sufficient. So you cannot write simply ERCP normal. You have to describe the procedure. This is something we need to learn. And this case had gone to Supreme Court. From 64 lakhs, the Supreme Court raised the compensation to 76 lakhs. And they specified that no time was mentioned against Dr. Jha's, noting that no ROP is seen. Entries made on page 100 and 102 are at the bottom of the page. The date 26/4 is mentioned in a different column, unlike other entries. No contemporaneous records to corroborate ROP screening was done, because the nurse's record do not mention any orders given by the pediatricians that call ophthalmologists for ROP screening. So there was no contemporaneous records maintained in this case. And this was the reason the court increased the compensation, and 76 lakhs was finally awarded. Similarly, use of abbreviations is to be avoided. Do not use abbreviations which everybody cannot understand. If you have used abbreviations and the case goes to court, when you are giving your reply with the abbreviations in bracket separately, please mention the complete full form of that abbreviation. Writing something like TPGBB in the corner of the prescription. What the doctor said, told patient to get breast biopsy. This was the full form of TPGBB. So this is not acceptable. Any abbreviations should be in this. The important, you write the patient's history of complaints, current symptoms, white parameters, clinical observations, and diagnosis. This is no diagnosis. Diabetic patient given injections, developed gas gangrene, amputation, death. There was no details written in the prescription slip. So it is not medical required to be maintained. Only patient. For outpatient prescriptions also are demanded. This particular court, these two judges from UP, one Allahabad and one that might direction the court imposing cost legal report and post-mortem reports in readable and clear handwriting. Any words?
Dr. Neeraj, I think the slides and things are sort of breaking. I don't know if it's just for me or whether it's happening across the board.
It's happening across. We are also not able to see.
Yeah.
Visible now?
Yeah, visible now. Visible now. Sound is clear as well. Yeah.
Okay. So maintaining outpatient record not compulsory. Yes, Indian Medical Council regulations mentioned that, but this is no longer going to be true for very long, because now you also have Clinical Establishment Act, and it is not a question only of what is mentioned in Indian Medical Council regulations. Then the issue is, should we be documenting in a written format on a paper, or should we all be shifting to electronic health records? Traditional method in India was manual, no doubt, but legally it is more acceptable as documentary evidence when you are writing these things. The problem is now more and more the computerized medical records have come in, neat, tidy, can be easily stored and retrieved. Possibility of easy manipulation remains, but there are particular ways in which it can be avoided. And the issue of electronic signature is still there. So in Indian Medical Council regulations of 2002, it was mentioned that efforts shall be made to computerize medical records, but Clinical Establishment Act says that clinical establishments shall maintain and provide electronic medical records or electronic health records of every patient. It does not say inpatient or outpatient, it says every patient. So you have to realize this, that should is more like mother's advice. Putar sharab pina changi gal nahi hai. It is your mother's advice. Shall is more like what your wife has demanded. You better come home at 7 p.m. You will not dare to counter that. And Department of Health and Family Welfare, Ministry of Health and Family Welfare, Government of India has issued guidelines regarding electronic health record standards. So with time, we need to change and move towards electronic health records. And the sooner we do it, the better it is going to be. The records need to be consistent. You cannot say that during an MTP, air embolism was the cause of death, where you have given 4 units of blood. So the court simply asked this question: if it is a question of air embolism which had caused death, why did you need to give 4 units of blood? So it should not be irrational record keeping. Similarly, in this particular case, in Skull Hospital, this was the Chandigarh case itself, DVT case with pulmonary embolism again, and TPA was to be given. So this TPA was requisitioned from outside from a chemist for immediate supply. And the hospital recorded says that this much TPA was given from 9 to 11 a.m. The supplier of the injection was called and his statement was taken, and he said he delivered the injection to the opposite party at 12:30 p.m. So the question arose, the medical records were saying the injection was started at 9 a.m. The supplier says I delivered the injection at 12:30. In having been in practice, I know what had happened in these expensive injections. We don't stock too much, we stock 1 or 2, and when a case like this is there, we ask the patient to replenish the one which is used without telling them we are going to start using from our own this thing. Because what happens with expensive injections is you use them and tomorrow the patient doesn't survive. The question of bill always arises. Next is the issue, how long to keep medical records? This is a question everybody asks me, and the reason is we have different guidelines, different laws covering this issue, with answer being totally different. We have weird laws in India. You can adopt a child. A man can adopt a child when he is 18 years old. Once I'm 18 years old, I can adopt a child. I cannot get married till I'm 21, and I cannot have my first alcoholic drink till I am 25. This is the law in our country. And this is what confusion is also there from various laws which are existent and applicable. PCP-NDT Act says something different. Consumer Protection Act says something different. Limitation Act says something different. And this Indu Sharma case, the CTG records, the court said, should have been maintained for 25 years. Though this was basically a quotation given from the Williams textbook, but this kind of a reference, once coming into a judgment of National Consumer Dispute Redressal Commission, creates a precedence. And what am I to understand? That we have to maintain these records for 25 years. So there is a problem regarding this, and this problem was compounded by this discovery rule, which Supreme Court brought in 2010. What does discovery rule say? This Consumer Protection Act says case can be filed up to 2 years after cause of action. I did surgery today, patient can file a case 2 years after I have done the surgery. Supreme Court says the patient can file a case 2 years after they found out I did the surgery negligently. Meaning, 1993 I did the surgery, 2002 the patient gets an ultrasound and finds I left a foreign body inside. The case is filed in 2004 and the court says this is okay, this is discovery rule. So this is a major problem. The question which comes is, how long exactly do you want to store the medical records, especially the paper records, and how much space you require, how to retrieve these records. So it was a nightmare. We have our own, which in humor I call the Nagpal's rule, but basically every 5 years, my recommendation is give an advertisement in 2 newspapers which nobody reads. Mind you, each and every word I'm saying is very important. It should be 2 newspapers, 1 vernacular, 1 English. The newspapers should be such that nobody reads. And the advertisement should say, we are going to destroy the medical records of people who have been treated by us more than 5 years ago. And anybody wanting the records should approach us within 30 days. Otherwise, these records will be destroyed. After 1 month, still do not destroy the records. Why the newspapers should be ones which nobody reads? Because if you give them in mainstream newspapers, you will be inundated with people wanting to claim their records. So you have to give an advertisement. It should not be very prominent. It should not be clear to everybody. And even after the advertisement, do not destroy the records. Supposing 10 years down the line, you get a notice and a case is filed against you. When you go to court, you take your medical records and you take the advertisement and give it to the advocate. If the advocate feels your medical records are good and he can fight your case on the basis of your medical records, he will fight the case on the basis of your medical records. If your medical records are not good, he will place the advertisement in front of the court and say, we gave an advertisement that we are going to destroy the medical records and nobody approached us within 30 days, hence we have destroyed the medical records. So at least one defense is there. Contemporaneous medical records. The records have to be maintained as the sequence of events are happening. For sake of good continuity of care, patients' records should be kept as up to date as possible, which means that information should be added to the patient's note as soon as it becomes available. I have a number of judgments on this issue. The problem why I'm wanting to highlight this is because some people think we have been treating the patient and maybe on the weekend we will write the notes. This kind of thing will create a problem. And I have judgments which are asking for literally minute-to-minute record when the procedure is ongoing. I have already given you an example where cardiac arrest has occurred, what time cardiac arrest occurred, who noticed it, who. So all these are the kind of issues which a person, when he's writing the medical records 1 week later or maybe 24 hours later, he may not be in a position to exactly remember. And contemporaneous records mean other persons should not have added something and you are writing for a time before what the other person has. Supposing 11 o'clock an event has occurred, you are writing the notes of that at 12 p.m. at 12 midnight, and in between somebody else has written medical records. These records no longer remain contemporaneous. This is the problem. And in this particular case, it is very, very clear that if you write many hours or days after death, this does not have any legal value. Contemporaneous records, I can give you multiple examples which courts have decided on this issue. And what to do with medical records in case of a medical accident. Now, supposing you have a sudden death which is unexplained. there is a mob collected outside. Please immediately photocopy and put into safe custody all the medical records available, preferably under personal supervision. Any incomplete record should be completed immediately, only if you are very sure complainant doesn't already have a copy. And get all concerned, including doctors, nurses, to write down notes in the file. Take affidavits from all doctors and nurses, attendants, helpers immediately after a medical accident. The same people working with you at the time of incidents may not give it later or may not be available to give it later. What not to do with documents? Do not do. This is something I already quoted the Supreme Court. When you make alterations in the records, it is tampering of evidence. And what was a simple civil case earlier will become a criminal case. So please do not tamper records. The same thing was there in Indu Sharma case. There was a lot of cutting, overwriting, white ink being applied. All these things do not help. And the judges are much, much more intelligent in picking out tampering and forgery than we give them credit for. And do not, under any circumstances, anesthetist is saying the patient was fit to give surgery, to go for surgery. The surgeon says the patient was very sick when I started surgery. So these are two different kind of conflicting records, and these will obviously create a problem in court. Bounden duty of the opposite party to have obtained history sheet, etc., till disposal of the complaint. You cannot say, I have destroyed the records when case is actually going on. And look at this case. Rahul Mahajan, son of Pramod Mahajan, and Bipin Moitra, he was secretary to Mr. Pramod Mahajan. They had champagne party with drugs and were brought in unconscious state to Apollo. Now, there was a lot of political pressure on the doctors in Apollo Hospital to not make a medico-legal case. So they did not make a medico-legal case. However, 3 hours later, Bipin Moitra died. Now an MLC had to be registered. But during that period, other patients came and their entries were there in the emergency register. Meanwhile, to mask the evidence of opiate poisoning, injection fentanyl had been given, patient had been shifted to ICU, basically to try and avoid making an MLC. The point, the judges, they went ahead and mentioned that I have no hesitation in coming to the conclusion that facts of the instant case clearly merit recording of 2 separate FIRs. The first is under NDPS Act, and the accused are Rahul Mahajan and Bipin Moitra, who has already died dead. The second FIR, the accused are the doctors and nurses of Apollo Hospital who have committed offenses in Apollo Hospital itself by tampering with records of the hospital. So petition to quash the FIRs was dismissed. And this is Delhi High Court which is dismissing. What medical records should be given to patients? Indian Medical Council regulations require within 72 hours if a patient has given a written request or an authorized representative of patient has given a written request, you have to provide the medical records. Lucknow bench, Allahabad High Court has given same thing in 2 petitions, and they mentioned very clearly that the government may deregister and seal such clinical establishments and may also impose penalty in case medical records are not provided at the time of discharge or within 72 hours of demand. Government was given directions that hospitals shall also maintain the record of each and every patient on the website, starting from registration of the patient till the date of the discharge. Very interesting judgments, unfortunately, coming from courts which reserve their judgments for 6 months to 2 years so that they can be written properly. And here, all case records of all patients admitted in hospital are expected to be uploaded on the website. So anybody sitting anywhere can check the patient's records. What happens to the confidentiality, I do not know. But nobody has thought it fit to challenge this judgment. So failure to provide medical records to patients on demand is negligence per se. You need to provide. And who's responsible for storage of the medical records? It is the hospital. It is not the doctor's responsibility. Confidentiality, yes, this is a very important case which was decided many years ago. HIV report was disclosed to the fiancé of the patient. The patient was a doctor himself, and the fiancé broke off the engagement. This case had gone up to Supreme Court, but the Supreme Court decided that this right to confidentiality was subservient to right to public health, and hence it could not be at the expense of health of others. So the case against Apollo Hospital was dismissed on this ground. So thank you so very much. I don't know how much time we have. Okay.
Yeah, I think we do have some time, a few more minutes. There are a series of questions on the chat box. I will just go through them. Some of them you have covered, but some. So Akshay asked, can logbook maintained during the training period be defense in case of treatment of rare cases?
Can logbook maintained during training
be a defense in case of treatment of rare cases? Maybe I don't know whether he's suggesting to prove expertise or whatever.
If your logbook is countersigned by your consultant, yes, definitely. But if your logbook is something which you have manufactured simply to produce in court, answer is no.
The other, Dr. Meera Luthra asks, what if the patient refuses to sign that he is not agreeing for a surgery, for example, LSCS?
Refusal to consent, you have a particular format, the patient refuses to sign that. All you have to do is write over there, the patient refuses to sign the refusal of consent. And sign it yourself, ask the staff nurse who's there to sign it along with you. Once this matter is recorded, we had a patient in PGI. This was a child who had inhaled a foreign body in the larynx, and the senior resident came. The senior resident asked the relatives, the patient's parents, who were both advocates, and asked them to give consent for bronchoscopic removal of the foreign body under anesthesia, and mentioned that yes, that can occur in this situation. They refused to give consent. They refused to sign the refusal of consent. On the card itself, he wrote on the side that patient's relatives have refused to give consent for the procedure, and signed her name, nothing else, went away. The patient's parents, after 2 hours or 3 hours, they must have phone calls here, there, everywhere. Then they decided, no, we should have got it done. So they told the resident doctor, no, now we want it done. Now in PGI, you don't organize things suddenly in minutes. And it took around 5-6 hours. And in those 5-6 hours, the child died. This case, they filed a criminal complaint. Bar Council got involved. Unfortunately, the director of PGI, he included 2 Bar Council members as members as part of the medical board, which was deciding the issue. This was unheard of, and we gave a legal notice to the director on this ground that whatever, in case there is an adverse decision by the medical board, we will be challenging that. So the thing is, your job finishes once you have properly documented that we have asked for refusal of consent and the patient refuses to give this refusal of consent. Aapne sign kar diya, you have done it at the proper place. The notes of 11:30 are there. At 11:40, you are writing this thing. After that, somebody else is writing, or you are writing your notes at 12:30. So this is contemporaneously documented. This is what the sequence of events is. The matter is over there and then.
The next question is, how many times we get night call from the hospital and we give oral instructions. So how do we deal with this now? Is it valid if we make a written mention of it the next day morning?
One, you have given oral instructions. It was the duty of the staff nurse to write down in the records, I have discussed the case with such and such consultant at this time, and telephonically I have been ordered to give this. Right? Because once the nurse writes that, it becomes part of medical record. Next day morning when you come, yes, I had received this phone call at this time at night, and I had advised this injection. Sign. That is the matter finishes there.
Thank you. Then how do we keep a medical record in OPD patients, as most of the time the documentation is on letterhead, which is handed over to the patient?
Electronic health records, that is what I'm saying. Now, Clinical Establishment Act is applicable in many states, and gradually we are going to move towards electronic health records. Once electronic health records are there, OPD or IPD will not make any difference. Everything will be documented and will be entered in the records.
Neeraj,
Yeah,
I just interrupt
Yogesh, I
because
think
it
there's
was-
just one more question. I'll just finish that.
No,
and
no,
come to
it
you.
was same as OPD records. That's why I'm asking him.
Okay.
Neeraj, I was just concluded doing a course with IAP about medical record, medical legal. A lot of things were there in that. It was a 3 months course. So Dr. Tiwari said that all OPD records or OPD sheets, you need to have a duplicate and you need to keep. I have never seen in my entire life, I mean, obviously I worked in government hospitals only, that duplicate or a carbon paper ke saath OPD records are written, but he insists that should be ideally done and all OPD records should be maintained. Now I see about say 100 patients in about 3 years. How do I manage all this?
The thing is, you will have to shift. This is what I am saying to electronic health records. What there I am using nowadays, though I used a software for more than 16, 17 years, but it was so old a software that when Windows came in, it became obsolete. Now I'm using a particular pen and I'm provided a prescription pad. When I'm using that particular pen, it is storing whatever I'm writing on my computer or on my mobile. It is also sending a copy of the image to the patient directly. So these kind of technologies have now come in. You do not need to keep a second record. I have seen Fortis and many hospitals have these pads where there is a carbon paper in between, and invariably both the carbon paper, the first sheet and the second sheet still remain in the pad itself. Nobody is taking out the second sheet to store it somewhere. So OPD records can only be maintained electronically, whether by these electronic pens or by the electronic health records. As problem in India is when violence occurs in hospitals, the first things which get smashed are the computers. So there is perverse pleasure people have in smashing the computers. The moment you do that, you destroy the records also. And it's not so easy in small and medium healthcare establishments to have records in different places. So the answer to OPD records is electronic health records. The OPD records cannot be maintained on these carbon sheets.
Again, unlike your clinic, in my OPD, I'll sit with 5 residents. And then that means that all those 5 residents need to have that kind of iPad or whatever, pen or whatnot. Otherwise,
Government of India.
In fact, I don't write any of the prescriptions in my OPD when I see 100 patients.
Government of India is coming out with a policy. I have already shown you the policy of 2016. Gradually, you will find government hospitals. In fact, some states have already mandated it. So you cannot give a handwritten prescription in many states. So it is all becoming computerized now, and gradually we will have to be by force. I mean, we are dinosaurs. I know we find it very difficult to accept new technology, but this is something which is bound to happen. And with more litigation happening, this is for our own benefit.
Thank you.
A couple of more questions. I think one is perioperative death you have answered. So I think Dr. Bagadi is asking, I think as a pediatric surgeons and with a lot of endoscopy, I think almost all the operations are recorded start to finish. So he is asking, do we have to give unedited operative videos to the patient?
So the thing is, I will strongly recommend do not advertise this fact, because some people, even I used to do it earlier when I used to perform endoscopies in my clinic maybe 15 years ago or 20 years ago. We used to have a pleasure within ourselves that the relatives sitting outside in the waiting room could see the procedure being performed on the screen over there. The point is, if it is understood by the patient that you are recording the procedure, then he is within his rights to ask for the unedited copy. Why I say you should not take video consent? This question was not raised. Why video consent should not be taken? The reason is the same. In India, we have so much fluctuation, voltage fluctuation. Sometimes electricity will come, electricity will go. When you are taking a video record in a continuation and electricity goes, there is a blip in between. Immediately, if I'm the defense lawyer, I will say this evidence has been tampered with. You understand my point? So these are the kind of things we should best avoid. Even if you record procedures for academic purposes, there is no need to declare this, so that it is not in the patient's knowledge, it is not in the relative's knowledge. And if somebody is specifically paying for a video procedure, record of the procedure, I mean, like when we do endoscopy, we charge separately for endoscopy with photographs, and we charge separately for video endoscopy. So 99% of the patients, because of the increased cost, they will refuse straight away. Once they have refused straight away, then there is no issue. So then they cannot ask for a video record. And whatever record you are creating for academic purposes, I will say do not disclose it to the patient's relative. Otherwise, they are within their rights to ask for it.
But isn't that unethical, Neeraj?
There is, what is most unethical is the way doctors are dragged to courts these days. I am a very, what do you say? I'm an activist more than a.
Yeah, I agree. No, what I'm saying is that as of today, even if you publish a histopath photograph without the consent in your paper, even that can be challenged and you would be penalized.
Yes.
So here we have recorded and we are not kind of sharing it with the and not taken consent also.
You take
there
a
where the
consent.
conflict is.
No. You take a consent for academic purposes. Your photograph or video may be recorded without declaring your identity. May. You are not using the word will.
Okay.
The moment you say the patient knows that all cases are being recorded, then they are within their rights. Then the only defense you have is that you want the recording, we will charge 5 lakh rupees for the recording. Understand this thing very clearly. The moment the patient knows a recording has been made, and they will find some fault or the other in the recording to say that you have tampered with the evidence.
Yeah, I think this is a, because I think I think there used to be a thing that a lot of people record and then go and show it on their phones and show pictures on the phones, which I think is quite a double-edged sword. I mean, it's nice and it has some sort of publicity value, but it's potentially can come back to haunt you quite severely.
I have, with Dr. Tiwari, I have had a lot of discussions on this issue. I am very, very clear on this issue. Video records are very, very dicey in India. And when you create a video record, be very, very sure that then under those circumstances, there is no blip, there is no glitch in the record in between somebody. Suddenly there is a jump in the video. It will be immediately said you have tampered with the record.
Dr. Meera Luthra, you have raised your hand. Please unmute yourself and go ahead. Yeah.
Hello, Sanjay, just to tell you, what I do, number one is that if I have taken photographs and video, like you said, we have it on the record, I might, after the patient is discharged, give him a couple of photographs for his record because it's going to be helpful in the future. But I have made it a policy to do it after the discharge, when the child is going home. Not at that time.
Meera, but you can't take a photograph without taking the consent. Even
No, but we have it on the consent. Yogesh, it's on the consent.
Okay.
No, this. And just by the way, Sanjay, you happen to be Yogesh, me, as well as Neeraj are all from CMC Ludhiana.
Oh, no, let me correct it. I and Neeraj are your students.
No. No, we are all from CMC and colleagues. Yeah.
Good. Yeah, I think on that positive note, I think we will draw an end to this. It's 8:05. Does anybody else want to make any comments or observations? If not, then anybody wants to speak up, please raise your hand or unmute yourself. Right. I think then we'll take this opportunity to thank Dr. Neeraj Nagpal for his very, very entertaining and very, very insightful and educative and warning talks that we have been hearing, and sometimes I think these are potential things that make you lose sleep. So thank you very much, and we will look forward to continuing this series in the coming months. Dr. Nagpal, thank you very much, and Dr. Sareen, Dr. Meera Luthra, and all others who attended and participated. Thank you very much and good night.
Thank you, Dr. Sanjay. Thank you, Dr. Sareen.